Hello, and welcome to the Alabama Public Health Training Network. Thank you so much for joining us for our program, Management of Infants with Suspected Zika Virus Exposure. If you have any questions about anything being discussed today, please call or email during our broadcast. The phone number and the email address are on your screen now and will appear later in the program. Also, the handouts, sign-in sheet, and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credits will only be awarded for 1 year for nurses, expiring on August 31st, 2018, and 2 years for social workers, expiring on August 31st, 2019. Now let's meet our presenters. Dr. Scott Harris, Assistant State Health Officer for Public Health Area 2, and effective September 1st, our new Acting State Health Officer. Dr. Karen Landers, Assistant Health Officer for Public Area 1, and Rachel Montgomery, Director of the Alabama Newborn Screening Program. Now let's get started with you, Dr. Harris.
Thank you, Ashley. Thank you very much. We appreciate all of you joining us here today. We're going to begin the talk by going over some basic information about Zika virus in terms of how it's transmitted, the degree of infection that we've seen in this country, and then how we go about testing. So to begin with, Zika virus is a single-stranded RNA virus. It belongs to a family of viruses that are known as flaviviruses, and that actually, the word flavus, or the prefix flavus, actually means yellow. And in fact, all of the viruses in this family are related to the yellow fever virus. Some of the other ones that you may have heard of include dengue, Japanese encephalitis, and probably the most commonly transmitted mosquito disease in this country, West Nile virus. This is an electron micrograph of a Zika virus, which is not that interesting to anyone unless you're an infectious disease guy, but I think that's actually kind of interesting. So most of the Zika virus disease that we've seen so far in the world over the past 2 years has been mosquito transmitted. The mosquito that typically transmits this virus is known as an Aedes species of mosquito. There are several different Aedes species that are known to us. The one that's best known, maybe to some, is called Aedes aegypti, and this is a mosquito that's present in many tropical parts of the world. It's a very effective, a very efficient vector for transmitting the disease. And then we also have, particularly in Alabama, an Aedes species that's known as Aedes albopictus, also known as the Asian tiger mosquito. There's a picture on your screen that you can see there, and if you look carefully, you can see stripes on the legs that must have reminded someone of a tiger, which is how it got its name. The Asian tiger mosquito is certainly much more common in Alabama than other Aedes species, as we'll see. These mosquitoes can transmit a number of diseases, not only other flaviviruses such as dengue, but additional viruses such as chikungunya, which occasionally makes an appearance in travelers coming to Alabama. These are mosquitoes that live very closely with human beings. They've learned how to adapt their life cycle to match the life cycle of people so that they can feed effectively. These mosquitoes tend to live in backyards. They tend to live around domestic water holding containers. They can feed in the daytime, which is a little bit unusual for some mosquito species. They can be very aggressive sometimes in the daytime, but also can bite at night. This is just a reminder of the type of environment in which you might find Aedes mosquitoes. This is just a typical flower vase with a drip pan underneath. Many people have these on their back porch or in the backyard. And a little bit of water standing in one of these containers is a really easy place for these mosquitoes to breed. These maps give you an idea of where Aedes species are located in the United States, and the reason this is important is that this shows us the range at which we might possibly expect some transmission of Zika virus should we have local transmission here in Alabama or in other states. On the left of your screen, you see the Aedes aegypti range, which is a little bit smaller than the more common mosquito in Alabama, which is Aedes albopictus. Albopictus has the ability to live in more temperate areas. It travels a good bit further north. Besides biting humans, it can also bite other animals, which sort of increases its viability in different parts of the country. So overall, it tends to have outcompeted Aedes aegypti, and we see much more of that here. This is a picture that I actually took near my home in North Alabama. This is a monument to a yellow fever outbreak that occurred in Morgan County. And I just put that here to remind you that we have often had outbreaks of these type of viruses in our state. The mosquitoes have been here forever, and the mosquitoes are still here. And really the only thing that's missing at this time is that we don't have a reservoir of disease in people. But in fact, 120 years ago, we had people traveling through the area with yellow fever. Local mosquitoes were able to pick that up, and it caused quite an outbreak in Alabama. Outbreaks of yellow fever actually were very common up until about the 1930s. And finally, I'll just show you this picture to remind you where the name Zika comes from. Zika virus is actually named after the Zika forest, which is a forest in Uganda. In the 1940s, a group of researchers from the Rockefeller Foundation traveled to Uganda and were actually studying primates there, particularly monkeys, looking for viruses. And that's when they first discovered that Zika virus was a virus. It caused an illness in monkeys that caused fever and sometimes rash, but generally seemed to be rather mild. And so we've known about Zika since that time, with only just occasional reports of cases. However, over the past 2 to 3 years, we've had a large outbreak, as you know, that's enveloped virtually every part of the Western Hemisphere. So I'll show you here on the screen the latest map we have of countries that have had cases of Zika or transmission of Zika. Now you see the entire United States there is colored in on the map. We haven't had transmission throughout the entire United States, but we have had some local transmission in parts of the country, as we'll discuss later, as well as throughout all of Central America and almost all of South America. Most of the flaviviruses, including Zika virus, have cycles that allow them to be transmitted not only in people, but also in any type of primate. So in tropical parts of the world, particularly where you have other non-human primates like great apes or monkeys, most of these viruses can continue to circulate even if you don't have human cases. And in fact, that's what seems to be the case with Zika virus. One of the more worrisome aspects of what's happened in places like Brazil is that even if there's an effective vaccine for people, or even if cases of Zika virus in people seem to decline, we suspect there probably will continue to be a reservoir of the disease because of apes, because of other primates that can get infected with mosquitoes and transmit and have a transmission cycle just like we see with people. Now, besides being transmitted by mosquitoes, there are certainly other ways that the virus can be transmitted. Maternal-fetal transmission is the most important, and what we'll be spending much of our time talking about today. This can be intrauterine, of course, as we'll discuss, but also perinatal transmission occurs as well. Zika has been really interesting in the fact that it can be transmitted sexually, which seems to be unique among most viruses, or at least most of the flaviviruses that we've discussed before. Zika virus can probably be transmitted by blood product transfusion. This has certainly been reported in other countries. It hasn't been confirmed in this country, but certainly is very reasonable and certainly probably does occur. There's been at least one case in the United States of a laboratory exposure in which a lab worker was stuck with a needle contaminated with Zika and acquired a Zika infection. And theoretically, Zika could be transmitted through organ or tissue transplantation or through breast milk. There are certainly no recommendations that would change breastfeeding recommendations at this time because of some risk of Zika transmission, but presumably it can be transmitted that way. There's also a single case known as the Utah case that you may have heard about. This was the first Zika death in the continental United States, and involved a caregiver of a man that had a suppressed immune system and had very high levels of Zika in his body. His caregiver is someone who subsequently became infected with Zika, and it's not really clear how that happened. There was no sexual contact. It was in a time and place in the country where there was no mosquito transmission going on. Presumably, this just occurred through some blood and body fluid transmission. That particular index patient had severe conjunctivitis. He had large amounts of ocular secretions, eye secretions, and so certainly that's a very reasonable way that the caregiver may have become infected. I think this is just like we think with almost any type of infection in a healthcare setting. You know, blood and body fluids ought to be considered contaminated, and so proper precautions need to be undertaken. So as we mentioned earlier, the first knowledge we have about Zika virus came from researchers in Africa in 1947, and it was really thought to be mostly a disease of monkeys, even though there were occasional human diseases that were recognized. Up until about 10 years ago, there were only a dozen or so human cases that had ever been documented. Although, because the disease is fairly mild and self-limited, it was presumed that there probably were other cases that just simply weren't reported. In 2007, we know of the first large-scale outbreak of Zika, and this occurred in Micronesia in the South Pacific. And then a few years later, there was an even larger outbreak that occurred in French Polynesia. Almost 30,000 people were infected at that time. Most of those people had fever and rash, and otherwise seemed to do well. There were no recognition. There was no recognition at that time of anything related to birth defects or long-term effects of Zika. Although subsequently researchers have returned to that data and found some interesting information, which we'll show in just a moment. But after this outbreak in 2013 and 14, the next time Zika really appeared on the world stage was in May of 2015, when we began to see outbreaks in Brazil. In 2014, the World Cup soccer tournament was held in Brazil. There were hundreds of thousands of travelers from all over the world who came into Brazil, and then very soon after that, it's when we first began seeing Zika. So it certainly makes sense that that might have been how it first made its way into that environment, when you have travelers from all over the world, particularly coming from the South Pacific, where there was an ongoing Zika outbreak. So this is really where we stand right now. These numbers that you see here are the most recent ones that we have from CDC, and instead of giving month by month or even year by year numbers, they've taken to sort of quantifying the entire epidemic. So going back to the beginning of 2015, the first U.S. cases were identified in late 2015. Going back to 2015 now, we've had in the continental U.S. over 5,000 cases of Zika, and these are all travel-associated cases. These are folks who went somewhere in the world where there was ongoing transmission, mostly to South America and the Caribbean, and then traveled back here and were diagnosed here. In addition to that, there are over 200 locally acquired cases. These occurred mostly in South Florida. Over 200 of them were in the Miami area. There were also a handful of cases that have occurred along the Texas-Mexico border in the Brownsville, Texas area. Of these 5,000 cases that we mentioned, over 2,000 of them occurred in pregnant women. This is a large percentage of cases. As you might expect, pregnant women are disproportionately being tested for Zika. Pregnant women who may have traveled are the ones who are getting tested. And so of these 5,000 cases, over 40% of those were in women who were pregnant. Almost 50 cases of documented sexual transmission have occurred. These were people who became infected despite not having a travel history, despite living in a place where mosquito transmission wasn't occurring, and who had a sexual risk factor for transmission. And then there are a couple of other outliers, as we mentioned, including a laboratory transmission. Now, these are 5,000 cases that we see in the continental United States. But contrast that with what we see in the U.S. territories and really in Puerto Rico. Over 36,000 locally acquired cases in Puerto Rico. This has been an unbelievable amount of disease that's occurred in Puerto Rico since the beginning of this outbreak. Of those 36,000, over 4,000 pregnant women have been found to have evidence of infection. This has just become really essentially a daily occurrence. They have a handful of travel-associated cases there, but almost all of the people there are being infected by local mosquitoes. And, of course, as a U.S. territory, people in Puerto Rico are certainly free to travel and come and go, and people from the mainland are free to travel and come and go. So we do have open travel between the continental U.S. and Puerto Rico. We have the same vector mosquitoes in much of the continental U.S., as we mentioned, and so that's obviously a big concern for us. This shows some pregnancy outcomes of what we have so far. This is through the end of July. According to CDC, we know that U.S. states have now had about 1,700 completed pregnancies in women that had some evidence of Zika virus infection. You see there are 91 live-born infants with birth defects and 8 pregnancy losses with birth defects that were consistent with Zika. This works out to a rate of about 5% or so. We're not comfortable that we're capturing every one of these people. Certainly, some pregnancy losses may occur early in pregnancy and may not come to medical attention. But somewhere around 5% of the completed pregnancies have had either live-born infants with birth defects or pregnancy losses. Our experience in Alabama so far has been that we've had a little over 40 confirmed cases. Sometimes we're not able to definitively identify a virus as Zika virus. Some of the testing sometimes can confuse it with other flaviviruses. So, for example, if a person is coming from a part of the world where they may have had yellow fever vaccine, for example, sometimes it can be confusing in trying to interpret the test. But in general, we say we have about 44 people who have Zika or who have something like Zika. Because these folks are traveling to parts of the world where the Zika virus outbreak is ongoing, presumably that's what most of those folks have. They probably do have Zika virus in most cases. We've had around 500 requests for testing so far. Those are disproportionately female, as you might expect, because we're concerned about women who are pregnant or who may become pregnant and their exposure to Zika virus. About 200 women who were pregnant have been approved for testing, and at last count, there were 5 women who tested positive for Zika virus who were also pregnant. So let's talk a little bit about the disease itself. Generally speaking, this is not a serious illness for most people. And in fact, for women who aren't pregnant or for men or for children, it's typically a very benign illness. The illness is asymptomatic in about 80% of cases. 4 out of 5 people don't know that they're infected. It's very unusual for people to be sick enough to be hospitalized. When people do have symptoms, they tend to last for just a few days. They tend to recover spontaneously without any particular treatment. They probably are immune. As far as we know, when someone's been infected, we don't think that they can get infected again, or at least we don't have evidence that they can. And deaths are extremely rare. There have been a small handful of deaths in people who were infected with Zika, and all of those folks were people that had other chronic medical conditions. They weren't normal, healthy people when they got infected. Okay. This is a photograph to give you some idea of the illness, and the slide really doesn't show this rash very well. The larger part of the slide is supposed to depict a rash, and in fact it's a pretty ordinary rash. You don't see much on the slide, and you don't really see that much on the patient. Again, remember, most people don't have symptoms at all, but in the 20% or so who do, a rash that's, a varying degree of rash can be present. The lower part of the slide shows you a red eye. This is a picture of conjunctivitis, and conjunctivitis is associated with Zika more than it is with infections by any of the other flaviviruses. So in a person who has a travel history, you may be trying to determine, is this Zika or is this some other illness? And conjunctivitis is certainly a clue that Zika virus is more likely. Again, for the most part, there are no real serious consequences for non-pregnant people who have Zika, but occasionally we have seen some patients who develop Dehombre Syndrome. You may know that Dehombre is a type of autoimmune nerve disease or neuropathy in which people develop a paralysis. It tends to be temporary. It's not in all cases, but in most cases it can last for a few weeks and then resolve. We know that Guillain-Barré occurs with a lot of infections. This is probably not anything that's particularly peculiar to Zika itself. People that have infection with Epstein-Barr virus, with Campylobacter, with HIV, with a lot of other types of infections can sometimes develop Guillain-Barré. And so Guillain-Barré is probably just a reaction to some kind of infection and is not really associated with Zika per se. But Zika has come under so much intense scrutiny, and we've had these thousands and thousands of cases. So it's not too surprising that we've identified some cases of Guillain-Barré that have occurred with it. Now, I mentioned some of the other viruses earlier, dengue and chikungunya. These are viruses that are transmitted in the same parts of the world as Zika. They're transmitted by the same mosquito as Zika. And in fact, their clinical symptoms look pretty similar. So when you have a patient who's been potentially exposed and you're not sure what it is, the way you tell is you test for all of these diseases. And in fact, when we test for Zika, we test also for these other diseases as well, for dengue and chikungunya. People can be infected with more than one at the same time. They can actually be infected with more than one that they get from the same mosquito, we think, from the same mosquito bite. The reason that it's important to distinguish is because each of these diseases have certain considerations that are unique to that disease. Obviously, with Zika virus, we're concerned about the possibility of transmission during pregnancy. Dengue virus can cause certain types of bleeding complications, and it's very important to know that if you're treating a patient with aspirin or with anti-inflammatory drugs. Chikungunya tends to cause joint pains that can last for weeks or months, and patients really need to know that prognostic information. So it's very important for us to distinguish between these three infections if we can do that. And in fact, when you get a consultation to do Zika testing, dengue and chikungunya testing will also be performed. There is no specific treatment for Zika. Like most viruses, we don't have any particular treatment for it. And actually, like most viruses, people tend to get well on their own even without treatment. So the current treatment is supportive, rest and fluids and pain medication and something to control their fever. As I mentioned earlier, we'd like to know that the patient doesn't have dengue or doesn't have chikungunya before we assume it's Zika, because that could certainly have implications in how you would want to treat them. We don't have any particular medicine to prevent this. There are vaccine trials that are underway, and actually vaccine trials that look very good. There are phase 2 trials now in which they're attempting to determine just how effective the vaccine can be. The candidate vaccines have been sort of proven as safe for humans in phase 1 trials. Now we're in phase 2 trials to determine their effectiveness, and that data actually looks pretty good. The main way to prevent this from occurring is to don't get bitten by mosquitoes. And the message that we try to get out over and over is that pregnant women should really consider postponing travel to areas where local virus transmission is occurring. If there's any possible way to delay that or to change that, we would want pregnant women to give consideration to doing that. When someone is infected with Zika, they may have a Zika virus in their bloodstream for a week or more, and so during that time they could be bitten by another mosquito, and that mosquito could infect someone else. So when people have been diagnosed, we want them to use insect precaution measures to make sure that they don't sustain transmission when they return home. When the health department is notified of a person with Zika virus infection, we have environmentalists that go to that person's home and educate the person and actually do an environmental assessment, look for breeding locations where mosquitoes might breed, such as standing water. And we actually distribute information in the neighborhood, reminding people to be careful about mosquito bites and to look for places where they can be breeding. So far, we've not had any local transmission of Zika in Alabama. All of our cases have been imported, but as we mentioned earlier, certainly there's a possibility that could happen here. Right. So let's talk a little bit about testing and who we want to test and who we don't want to test. First of all, if a woman's pregnant, she should consider postponing travel to an area where Zika is present, and that's the main message I'd like to get across. If a woman absolutely has to travel or her travel is unavoidable, then it's really important that she exercise just scrupulous insect protection measures. It's very important to avoid mosquito bites during the trip. Use EPA-approved insect repellents, use screens or bed nets, avoid places and times of day when mosquito activity is elevated. She should do everything possible to make sure that she doesn't get bitten if she can possibly prevent it. Remember that Zika virus is transmitted through sexual contact as well. And so far we've had about 50 cases of documented sexual transmission. This adds an extra dimension to the whole situation in that women who don't travel but who have a partner who travels suddenly could be put at risk for Zika if safe sexual practices aren't followed. So pregnant women who have a male partner who's traveled to a Zika-affected area should ask their partner to consistently and correctly use condoms or consider abstaining from insertive sexual activity for the duration of the pregnancy. So if the woman has 1 month to go or has 8 months to go, they should consider using condoms for the duration of the pregnancy. If there are couples in which a man has had confirmed Zika virus infection or clinical illness that seems like Zika virus, or if a man has simply traveled to an area where Zika virus transmission is ongoing, even if he did not develop symptoms, then he and his partner should use condoms or abstain from sex for 6 months after the travel or after the onset of illness. So this is for women who are not pregnant, but whose male partner traveled and either became infected or could have become infected. Remember that 80% of people don't have symptoms. So a man who travels to a country with Zika virus transmission and comes back without symptoms may be infected still. And sexual transmission and pregnancy occur through the same route. And so that's why this couple needs to use barrier contraception or avoid sexual activity, again, for 6 months. For whatever reason, Zika virus tends to live in semen longer than any other body fluid. In most cases, the virus clears much sooner, but it remains for a very long time in semen, and so it can be transmitted for several months, at least a few months, after infection or after exposure. Now, there are several ways to get Zika testing done. In the first part of the epidemic, most of the testing was being routed through state health departments. CDC had the only site for testing Zika virus in Fort Collins, Colorado. And so health departments were sort of the gatekeeper for managing that. There are now many private laboratories that offer some type of Zika testing. We would ask you to please still consult with us if you want to seek testing. We like to know about tests for Zika and related viruses. Even if those tests turn out to be negative, that's a reportable disease that the health department needs to know about. And many times we're able to help you with determining exactly what type of test needs to be done, or if testing in fact needs to be done at all. So even though we're not necessarily involved in all the testing that's done, we'd still like to be part of that process if possible. So these are the current recommendations for pregnant women who are symptomatic with symptoms that seem compatible with Zika virus disease and who have a history of travel during pregnancy. Then we want to test those people. Anyone who has a risk factor such as sexual transmission risk or travel history and who has symptoms, then we want to test that person every time. What's happened lately is some changes in thinking about how we deal with asymptomatic women. For most of the past year and a half, even women who were completely asymptomatic, who had a risk factor for Zika, if they traveled to an area with Zika or their partner traveled and they had unprotected sex, we still wanted to test that woman. We felt like it was important, because she was pregnant, to know whether or not Zika was present. CDC has just in the past month updated these guidelines somewhat, and so now the recommendation from CDC is that this should be decided on a case-by-case basis. That is, a pregnant woman who has no symptoms at all, even if she has some risk factors, should talk to her provider about whether testing is necessary or not. In Alabama, we've not actually changed our guidelines at this point. Later this month, actually later this week, there's going to be a meeting of several important stakeholders and CDC to try to further refine this process and make generalized recommendations. I can tell you at this point about half the states in the country have not changed their guidelines or continuing to test all asymptomatic pregnant women, and that's what we're doing at the moment. There are some states that have gone to this new position, which is to not necessarily test those women, but to decide that on a case-by-case basis. So hopefully we'll have that clarified for everyone within the next few weeks as the experts come together and all the stakeholders supply their input for that. All right. Finally, I'll say that for asymptomatic women who have ongoing exposure, that is, these may be pregnant women who live in a place like Puerto Rico or in a place where transmission is occurring regularly, or who travel frequently back and forth, or this might be someone whose partner travels frequently back and forth and who's not using barrier contraception. So for pregnant women who have no symptoms but who have ongoing or repeated exposure, then the recommendation now is to test those women 3 times over the course of their pregnancy. So the first test at the first time they seek prenatal care, and then to test them at least twice more. There's been some changing in our understanding of the methodology involved in different parts of the testing, and so it's a little less clear than it was about a year ago as we learned more about the testing. And so basic RNA testing 3 times during the pregnancy would be the best way to determine if a woman's become infected during pregnancy. All right. At this time, I'm going to pass the clicker over to Dr. Landers, and she's going to continue our talk.
Thank you, Dr. Harris. And thank you all again for participating in this important meeting. Before I go forward, I would just like to emphasize something that Dr. Harris said, and that is that tomorrow, actually, the CDC will begin a series of meetings discussing with interested stakeholders such as the American Academy of Pediatrics, the American College of OBGYNs, and other expert bodies regarding any changes or recommendations in Zika testing. What I think will come out as a result of this is not going to change as much about our pediatric management as it will about our early pregnancy, late pregnancy, or overall obstetrical management. But what I'm going to talk about today is the current guidelines as it relates to pediatrics, recognizing that, again, this information will be ongoing over the next couple of weeks, and hopefully we will have, again, even more guidance. As we know, for us, Zika is not a new disease, but I guess we can call it an emerging infectious disease from the standpoint of it emerged a couple of years ago on our radar as physicians and public health officials. So we had to learn very quickly about this virus, and we are still learning. At the end of my talk, I will also refer you to some very, very good websites that I think can provide additional information. Again, as we talked about earlier, this information possibly could change, but at this point, this is what we know. What I would like to talk about today briefly is some brain abnormalities and other physical findings that we can see in what is now defined as congenital Zika syndrome. I will also discuss diagnostic testing methods from the standpoint of what should be tested and what fluids should be tested and how this should be tested, recognizing that we always have an excellent resource in the Bureau of Clinical Laboratories here in Montgomery. And finally, I will spend some time on the recommendations regarding follow-up of infants with suspected congenital Zika or Zika exposure. And again, to remind everyone, this is not material that we can remember every detail. I myself have in front of me what I carry around, and that is, I call it my Zika pocket guide or my Zika sheet. And if there are changes, I print this and carry it with me. Those of you that are technologically savvy may want a copy of this on your iPad. But again, you can't remember every detail, but it's important to be able to access your resources when persons ask you questions. So let's talk about Zika and newborn examination. I'm a pediatrician, so obviously for me, the physical examination is an extremely important part of that initial assessment of all infants. But specifically, when we're talking about Zika, we need to remember that infants born to mothers who are known to have laboratory evidence of Zika virus, in other words, those patients that, as Dr. Harris mentioned, have already been tested, should have a comprehensive examination at the time of delivery, should certainly have a neurologic assessment, as again, we pediatricians all consider this to be second nature. But again, also in the Zika exposed infants or Zika documented infants born to mothers with documented Zika, these infants should have a postnatal ultrasound, and we obviously don't do that as part of a routine exam, but we would in potentially exposed infants. Now let's talk about other aspects of the examination. Again, not only should we be doing a thorough physical examination, but also, as we know, standard newborn hearing screening is recommended in infants, and of course an ABR specifically in infants that are known to have or suspected to have been born to a mother who had Zika. An ophthalmologic examination, and again, this is not something that can be done just by a routine quick look at the eyes. This has to be done by an ophthalmologist that is skilled in evaluation of the infants. And again, there are other laboratory imaging and consultations recommended by the AAP and CDC and ACOG guidelines, and I will speak about those later. I will actually show you a chart which I find very helpful myself. Now, when we're talking about other considerations, we have to remember that there are situations where women may have had exposure and had no testing, and that presents a conundrum to we pediatricians at the time of delivery. And I think that the AAP and the CDC have done a very good job in guiding us regarding how we should manage those infants. Additionally, what if we have negative testing in a mother with ongoing exposure? How should we manage that? Well, again, Dr. Harris outlined what we should do with women who are pregnant with ongoing exposure. We also want to talk about negative Zika testing in a mother 12 weeks after exposure. Again, that can be a bit of a conundrum for us, but the AAP and the CDC have given us guidance on how to handle these children. And additionally, we have to remember, as I received a call last year about October, again, I was thinking we had mothers we were testing for Zika around the first of the year, and somehow I felt like in the fall we were going to have infants born that would need to be followed up. So I actually received a phone call last October on a Friday afternoon at about 5:30 from a neonatologist who was very concerned about possible Zika in a mother who had not been tested during pregnancy, but her infant had many concerning physical findings. And of course, obviously at that point we were new to some of this material, but we tested that infant. That infant actually did not have Zika, but it was important for us to be able to have expert guidance and to provide information to that physician who was on the front line and just needed to know what they needed to do regarding this infant. Now, we're talking about microcephaly. I think this is, for me as a pediatrician, this is a really, really important point. Microcephaly, by definition, is an OFC that is less than the 3rd percentile, and again, based upon standard charts for age, sex, gestational age at the time of birth. And this should be very, very carefully measured, and we have to remember that we have to compare this related to other factors, other findings that the infant may have. But the OFC is an extremely important component of our examination. And when I was a young doctor in training, this was something that one had better do correctly and that one had better do before the attending pediatrician came around, because they always ask, did you do this yourself, rather than delegating this to someone else. So again, it really became something that was extremely important to me, and again, it's just an important part of the pediatric physical examination. Now, if we're going to do a head circumference and we're going to do it correctly, certainly in infants that are suspect to have been exposed to the Zika virus, or if we know that a mother has had Zika virus during her pregnancy. Well, first of all, we do want to measure during the first 24 hours of life. And I know there might be some neonatal nurses out there right now that are saying, okay, well, what about molding? Well, what about some of the situations that we see, right after birth, and we measure and then we remeasure. But in the case of Zika, we certainly want to measure within the first 24 hours of life. And we also want to use a tape measure that cannot be stretched. I actually have a tape measure here with me today, and also being interested in infection control. One thing that I remind persons is, this is not your tape measure that you just pull out of your pocket and go from patient to patient and use this. Again, that's a no-no for infection control. But these paper tapes, and of course there are many of these that are out on the market, but these are very, very useful, and I can guarantee you that if you stretch this, it will break. I have been known to destroy a few of these in my time. We want to wrap the tape securely around the head, around the widest possible circumference of the head. And it's extremely important, again, that we do this in a correct manner. Other components of measuring. We want to measure 1 to 2 finger widths above the eyebrow, obviously, and measure from the most prominent part of the back of the head, the most prominent part of the occiput. In addition, measure 3 times and record the largest measurement to the nearest 0.1 centimeter. Again, don't just measure one time, okay, I've got it. We measure, reposition your tape, remeasure, reposition again. This is to make sure that we have an accurate measurement and that we're not really having measurements that are question or suspect. I want to mention, I don't have this to play during this presentation, But I want to mention that there is a YouTube that I have viewed, and I find this to be an extremely helpful guide in terms of measuring heads. Again, there are many neonatal nurses out here that are very, very skilled at this, many L&D nurses that are very, very skilled, but I like to just demonstrate some of the pitfalls of doing a head circumference. And I brought my plastic baby along with me today to be able to do this. And again, being a pediatrician, let me just say that, I like centimeters, so, to measure in centimeters. These tapes have either side. You want to pull out your tape and certainly measure, again, a couple of finger breadths above the eyebrow. You want to give the kid the benefit of the doubt in terms of measuring the best circumference that you can. So you want to carefully position your tape. Usually I would be standing for this, standing over the infant, but we want to have our tape measure, again, the widest part of the head, the most prominent part of the occiput, and we want to position our tape measure all the way around and make sure that we have it lined up correctly. Some of the pitfalls, as we've all seen, is most babies won't lay here like this and let me measure the head quietly. So I may need some assistance from someone else in order to have a proper head measurement. What I generally see with infants is they like to rock their head back and forth, like to move around a little bit in order to get this off of their head, get this off. But again, we want to measure correctly, we want to document, and then of course we'll reposition this tape measure. We'll take it off and reposition, again, going at the most prominent part of the occiput, coming around in front of the eyebrows, repositioning our tape and looking for gaps. I like to really position and run my fingers around the tape to make sure that I don't have gaps, to make sure, again, that we have a proper measurement. One thing that can happen is sometimes our tape will be a little crooked, and we'll pull it this way and that way. But again, 3 measurements with a tape measure that is a disposable tape, certainly a tape that you can use for that infant. And I like to put the kid's name on it. That's just me. I just like to, keep everything consistent. But I think it's extremely important, and as I said, the YouTube can do that much better than I can, but make sure that you have an accurate head measurement on the infant, because again, we want to give the best information possible whether this child meets the definition of microcephaly or not. But again, that's not the only finding. It's just one of the findings that we are looking for in children exposed to Zika. Now, when we're talking about testing, one thing that we want to remember, again, as Dr. Harris so eloquently put it, we want to test the women appropriately. We want to test the persons who need to be tested. But we have to be aware that there will be times as pediatricians that we will be confronted with situations where women were not tested during the certain period of time after exposure to Zika that they should have been, 12 weeks or so. And these women may also not have been tested at all, as was in the case that I dealt with last year. So certainly it makes it pretty straightforward if infants are born to mothers who have laboratory evidence of Zika infection during pregnancy. That makes it pretty simple that we test those infants. That's a pretty easy one. But if we have infants with abnormal clinical findings that are suggestive of congenital Zika, and we have a maternal epidemiologic link, or we have a concern, and again, as this situation I had last year, this neonatologist had a significant concern, and we weren't really able to establish a link, but it really did appear to be highly suspect that this could have been a congenital Zika. So again, we have to respect the knowledge of our clinicians that are there looking at the infants at that time. Certainly, we will follow our chart, and I will go through that a little more in a moment, but we'll follow the guidelines in terms of selecting infants that need to be tested that don't have clear guidance. But again, we're talking about infants that are born to mothers who have been tested positive for Zika. Well, we want to test within a couple of days of birth. And again, it was very interesting last year as we were struggling with knowing when to test and how to test and what specimens were necessary. But I think we've got that down now. So again, we want to test within a couple of days of birth. And we also want to test on the infant's serum and urine, and if clinically indicated, the cerebrospinal fluid. Now, I want to speak to this just for a moment because we all know that doing an LP in a newborn infant is not an easy procedure, and this is something that we pediatricians want to determine if this is a test that is necessary. There is some data to indicate that if we have certain situations in infants that we really suspect of congenital Zika, but we don't have a clear epidemiologic link, that it could be appropriate to do a CSF. Now, again, that's a lot of if and could be and whatever. So I think we're sticking with the clinically indicated, but this is something that ID physicians, along with neonatologists and other physicians that are starting to deal with more literature related to Zika, can help us in guiding us about whether or not to do a CSF. If the CSF is done, then obviously you're going to do a PCR and an IgM on that CSF. Now, what tests do we perform? Well, again, I'm going to talk about that more in a moment when I have the chart ready to be reviewed. But again, in infants that are tested, we want to test the Zika virus RNA nucleic acid test to make it just really simple, the RNA NAT on the urine and the serum. And we want a Zika virus IgM on the serum. And this is something that last year there was a lot of concern. And again, I go back to being a pediatrician, and I know that drawing blood on babies is not the easiest thing in the world to do. And so many persons early in the description of some of the information that we were talking about were saying, could we just not test cord blood? Could we just not do that instead? Well, no. You have to test the infant serum, not the cord blood. Now again, if we do CSF, if it's clinically indicated, then we obviously want to do the NAT and the IgM. And coming up in the next part of the presentation, I will go through a chart that will provide additional information. I think this might be a good time to take a break before I talk a little more about congenital Zika syndrome. So Ashley, I'll turn it back over to you.
Dr. Landers, we'll take a short break. We'll be right back. Thank you so much for joining us. Welcome back. We'll continue our discussion with Dr. Landers now.
Thank you, Ashley. We want to go back now after we have spoken for a bit about maternal Zika, infants born to mothers with Zika or suspected Zika, the testing of those infants, as well as some discussion of the specific finding of microcephaly, and talk about 5 features that have been identified as congenital Zika syndrome. Now, the first feature, and again, as I mentioned, microcephaly, this is really the most significant feature that I think we were discussing a couple of years ago when we started looking at more Zika, specifically in Brazil. These infants have severe microcephaly. And I think that the important factor here, and really the embryologic factor that I find most interesting here, is the way that the Zika virus actually invades excuse me, into the neural tissue, and as a result of that causes microcephaly. Excuse me. But as I was mentioning, the microcephaly is so severe that actually, with this invasion of the tissue and the destruction of the tissue, these infants will develop what really appears to be a collapsed skull, and you can actually see significantly redundant scalp tissue with these patients. So again, it's quite a devastating microcephaly. Certainly other things that can be seen in congenital Zika are specifically decreased brain tissue or cortical thinning, which can be seen on the ultrasound, as well as calcifications. The ocular abnormalities, as I mentioned earlier, you can see retinal modeling, and you can also see macular scarring. Again, these are factors and these are findings that ophthalmologists would be able to identify. One of the other interesting features that has been identified with congenital Zika has been congenital contractures or arthrogryposis. And finally, these infants are very hypertonic soon after birth, a lot of stiffness. And there have been other associated factors, but again, these are the 5 factors that have specifically been identified, and that is microcephaly, decreased brain tissue, ocular abnormalities, congenital contractures, and hypertonia. Now, we also, again, want to focus in a little more on the central nervous system here. As I mentioned earlier, the microcephaly and the calcifications, and again, the cortical thinning, the cerebral atrophy. Also, abnormal formation. You can see on brain imaging corpus callosum abnormalities and other abnormalities, again, porencephaly, hydranencephaly, ventriculomegaly, and hydrocephalus. And of course, some of these infants will go on to require shunting. Other findings that you can see, and again, as I mentioned earlier, the collapsed skull, which is quite significant, the overlapping sutures, and the scalp rugae. Again, the scalp folding. There are pictures of this for any of you that are interested. The American Academy of Pediatrics on its website has a Zika section that has 3 very excellent archived discussions and a lot of pictures that I think can be very useful, as well as these infants may have pre or postnatal IVH. Now again, we can also see neural tube type defects, anencephaly, encephalocele, and spina bifida. Certainly we can see this without Zika. We can see this in other infants, infants that have not been infected with Zika. But these are just some additional findings that have been reported in literature. Now, as I mentioned, the ocular abnormalities, again, the pigmented macular area, the atrophy, the modeling, these are all findings that we need an ophthalmologist to document so that we can ensure that we have an appropriate screening and an appropriate baseline for these infants. Again, even more ocular abnormalities. Now again, some of these can be seen in other congenital infections. Coloboma, for example, cataracts. So again, we don't want to say if we have a child with this, well, automatically they have Zika. There may be another reason, and we certainly need to look back at the epidemiology of the mother and any testing that might need to be done. But all of these things have been reported in literature. The arthrogryposis, I think, has been quite significant, and there's an excellent article, and I believe it's in the New England Journal, but it is an excellent article on the arthrogryposis that has been seen. And certainly you can also see findings such as clubfoot. Again, see this with other congenital abnormalities besides Zika, but it is something to be aware of. And again, a lot of people will speak to congenital dislocation of the hip. I personally prefer the term developmental dysplasia of the hip. But again, infants that have, abnormalities in the hips, and this can be determined on a good physical examination. And every pediatrician from the time of medical school to early residency is taught about proper examination for developmental dysplasia of the hip. And these findings, I hope you can appreciate from the screen. These are just several specific pictures of the contractures that were first described in some infants that had congenital Zika syndrome. But again, these are very significant. You can see a slide with the dislocation. You can also see a clubfoot. I believe that's in the 4th picture there. Again, several conditions that can be, joint conditions that can be associated with Zika. We don't want to neglect hearing loss. We know that hearing loss can occur from, again, many reasons, but specifically because we in Alabama are very focused on newborn hearing screening and following up infants to ensure that these infants do have appropriate evaluation and testing. Obviously, we're going to do postnatal testing. We're going to follow standard procedures in infants that have been born to mothers who might have Zika. We want to ensure that we use an ABR on these infants. I think that's extremely important. So what do we do? What do we do? You know, if we have an infant that has been born to a mother with Zika, I think that is a little clearer on all of the follow-up. If we have a mother that was not tested for some reason or did not need to be tested, but now we have an infant with abnormal findings, again, that makes it a little more difficult. But at this time, we have guidance, we have algorithms, and these should be followed in order for us to appropriately assess these infants. Again, there are test interpretation by CDC. There is the algorithm. We also will talk a little bit about our newborn screening registry. These infants need really close follow-up and just ensuring that they get the care that they need. Again, this is not a simple follow-up. These infants are going to need multiple referrals to multiple specialists to ensure that they receive the most appropriate care. Now we're going to go to a chart that is from the CDC, and given the time frame that we have, I hope you can see this a little clearer on your screen, but I will try to talk a little bit about how we approach the infants in the context of the maternal screening. Now, certainly, I think the most important factor, and the first thing we need to look at is, does the mother have lab evidence of Zika virus? If the mother has lab evidence of Zika virus, then that's very, very helpful because it leads us down this pathway. So if the mother has evidence of Zika virus, then the next question leads us into this block. Does the infant have abnormalities, as I spoke of earlier? Does the infant have abnormalities that are consistent with Zika? Again, if the infant has some of the findings that I mentioned, such as microcephaly, just being one of the factors, such as arthrogryposis. But again, if the infant has these findings, again, yes, that leads us into our initial evaluation. We go back to, certainly we want to do the routine newborn screening. We want to do the routine care. We want to do an appropriate head circumference on these infants, as well as other parts and components of our physical. But these infants, again, being born to a mother that has lab evidence of Zika, the infant has findings, we now move on to our head ultrasound. And as I mentioned earlier, cortical thinning, calcification, these are issues to be concerned about. And finally, the testing of the infant. Remember, we spoke about a moment ago the testing that needs to be done, urine and serum. We want to do the PCR. We want to do the IgM on the serum. We'll do the PCR on the urine and IgM on the serum and PCR on the serum. And in addition to that, if we had CSF, if that were some other indication, then we certainly might do testing there. This is a consideration we have to be aware of, and we want to ensure that the infants have appropriate follow-up. So should these infants be referred to a hospital that has a higher level nursery? And again, that would be an individual clinician decision. But we also, if we choose to keep this infant in our facility, then we would want to do other blood testing, again, CBC, metabolic profile, LFTs. Certainly we would want to consult with an ophthalmologist, as I mentioned, ABR, and consider further neuroimaging as appropriate. I think we have to remember here that we don't have ophthalmologists. Just for example, we don't have ophthalmologists in every setting that could readily come in and do this evaluation. So we have to be aware that this situation may require referral. Well, before we leave this box, and again, I hope this is showing up on your camera, we want to look at laboratory testing. As I mentioned, laboratory testing, and we'll go to a chart in just a moment on that. Does the infant have positive lab test for Zika? And again, we'll interpret that shortly. If the infant does, that leads us into a category of follow-up, which I will review shortly. Let's say, for example, the infant tests and does not have evidence. Again, that will lead us into a different category for testing. Now, as I mentioned, does the infant have abnormalities? If the infant has abnormalities, we go down this path. If the infant doesn't have abnormalities, and I find this very useful, we are still going to do our standard screening. We're still going to do our standard examination. We're going to do our ultrasound, okay? Because remember, this was a child born to a mother who had Zika. So we're going to do our ultrasound. We don't want to miss anything. And in addition, we're going to do our testing. Let's make sure that we do our testing. And again, follow the algorithm. Well, let's talk about what I consider a bit more difficult scenario, and that is the mother that was not tested or was tested outside of the window. What do we do with those infants? Well, we go back to our good history and physical examination. We find out more about the epidemiology with the mother. Then we do our physical examination on that infant. Does that infant have some of the abnormalities that I mentioned earlier with congenital Zika syndrome? If the infant has consistent abnormalities, we're going back down a path here. We are basically going to duplicate what we have over here in a situation where we know that the child was exposed. We know that there was maternal Zika. If this child has consistent findings, we're going to go down that same path, and we're going to test our infant. We're going to do our serum and urine testing. We're going to test the serum for PCR. We're also going to do an IgM. We're going to test the urine for PCR, and if indicated, if clinically indicated, we would do a CSF. Again, we're going to be as meticulous over here as we are with the known exposure. But I think another factor here that we have to look at is if the infant has, again, we do the testing of the infant, let's say, tests negative. Again, it takes us to a different category. And finally, what do we do if we have a mother that was not tested but epidemiologically could have been exposed? Then we don't have abnormalities with the infant, but we still want to be aware because there can be some soft findings that we want to be aware to follow these infants appropriately. Well, one thing we want to do, as we were doing over here, we want to test the mother. In both of these categories, we're going to test the mother who was not previously tested. I think a factor here we have to consider is testing the placenta. And again, our BCL is absolutely wonderful in providing guidance on the specimens there. We certainly want to do our physical examination, our head circumference, as we would do anyway, do our standard hearing screening, and we'll still do our ultrasound. Let's don't forget to do our head ultrasound. What we would do here, if the infant had no findings, but had potentially been exposed, but we had no maternal testing, we would see what our maternal testing showed, and then based upon that, we would test the infant. Again, this is in our no findings on the infant, maybe potential exposure, but infant has a totally normal physical examination, does not have microcephaly. Our exam was normal, our hearing test was normal, our ultrasound was normal. So what do we do? Again, this is an excellent chart, and even though we know that there are going to be more factors and more information coming out within the next couple of weeks, I expect this chart to be somewhat similar because the discussion centers largely around testing mothers versus not testing in certain situations, but we're still going to have follow-up for infants. So let's go to our second chart, and I'm not sure how well this chart is projecting, but what I want to do is really highlight the upper portion of this chart. If we can do this, really zoom in a little more. And again, this chart is available on the CDC's website, and this is what I call my pocket manual for Zika. Interpretation of laboratory testing. I think this is critical to what we're going to be doing. So let's say we have an infant, we tested the infant, we tested the urine, we tested the serum. We won't talk about CSF for right now. But let's say, for example, we have a positive PCR, serum positive PCR, a positive or negative IgM. Okay, if they have a positive PCR on this infant and a positive or negative IgM, then this infant has congenital Zika. Okay, so we need to follow through on that. Let's say our PCR is negative, but our IgM is positive. Well, that puts us in the possible category. But we go back to our chart because that is not going to change, that we're going to do meticulous long-term follow-up with these infants. And finally, let's say that we have a negative PCR, a negative IgM, then these children are negative for congenital Zikas, but we need to look within the context of what we're dealing with. It is possible that we may have a situation here, depending on the timing of the maternal testing and based upon our follow-up, that we may need to do additional testing later. But again, this does give us very helpful information in terms of interpretation. Now, this laboratory testing chart, which again is available through the CDC, then leads us into a checklist of what we need to do prior to this patient's discharge and then following the patient's discharge. Certainly, neurologists, infectious disease specialists, ophthalmologists are going to be key to this. One factor that I think, if we look back at the embryology, we can then realize is if we have a collapsed skull, if we have a virus that has invaded the neurons, if we have a situation where basically we have an extreme level of CNS damage, then it follows that we could certainly have hypothalamic pituitary axis problems. And these children can actually also have thyroid issues or congenital or hypothyroidism. So we want to involve an endocrinologist. And that might not be something that initially we might think, okay, neurologist, ID, PT, certainly want to get ophthalmology in here. But we might not think about an endocrinologist, and yet endocrinologic testing is extremely important. Now, a bit further down the road, we're going to need other specialists, such as our orthopedist, and we don't want to forget that follow-up needs to be done. So we have an inpatient, an initial checklist. We have an outpatient management for infants that have consistent findings, and we have an outpatient checklist with infants that may have laboratory evidence but don't have the abnormalities. Again, it's very important for us to have our checklist so that we will not miss anything with these infants. Finally, I want to go to the outpatient management guidelines, which, as you saw on the algorithm, depending on which path you go down on the algorithm, then you are further directed to additional parts of the checklist. And as I said, this has been invaluable to me, and I've been fortunate to see the progression of this scientific guidance from the beginning of our discussions about Zika to the very high-quality products that have been developed for guidance with Zika. And again, on our first chart, this is a 3-page document, our first chart, just to mention infants that we know were born to mothers that were positive for Zika. Those infants have findings that were consistent with Zika. Those infants tested positive for Zika. Then we have an outline that not only gives us the testing that we should do, but what I like about this is that it specifically gives us benchmarks on when this testing should be done. I mentioned thyroid functioning, neurologic examination follow-up, second neurologic exam, repeat thyroid testing, again, reminding ourselves that with this level of brain abnormality, we certainly want to follow up. And again, also with our ABR, as well as the other portions of our checklist. And again, based on how well the infant falls out in terms of physical findings, testing, positive or negative, our first part of our algorithm leads us into each category, which, as I said, I find to be extremely helpful because this is something that we can put in front of us and remind ourselves, okay, I need to do this, I need to do that, I need to ensure that this testing is being done. As well as, I'll skip to, because I know you all would want to read this more for yourselves, but I will skip to infants with no abnormalities consistent with Zika, negative for Zika virus infection. Well, what do? Well, we say, okay, we don't worry about it. We say, no. We are aware that there is no information about this infant at this point in time and they've tested negative. But we as pediatricians want to continue to monitor those children. And we're going to do our routine physical examinations. We're going to do our periodic evaluation as we always do. We're going to do our developmental screening. We're going to ensure that that infant is appropriately developing based upon the age. So certainly it does not alleviate our doing our appropriate examination or evaluation. But again, I find this very helpful. I've received many phone calls regarding infants and concerns about Zika, even in situations where mothers did not go anywhere other than their own backyard and they were bitten by a mosquito, and so they were concerned. And again, have received many calls from pediatricians to discuss this. But I find this to be a very useful tool, and I'm confident that regardless of what changes will occur on this new guidance, that we will still have a product, we'll still have a tool that we are able to use as pediatricians. So I'm going to go back to my other slides, if possible, here. Okay. Let me see if I can flip through these. And let me go to references here in the last couple of minutes. And I really want to spend some time on references. Again, this as an emerging infectious disease has certainly captured our interest because we want to do all we can to reduce the risk to women during pregnancy so that we can prevent the problems that I have just discussed in terms of congenital Zika syndrome. Again, I go back to saying I'm a pediatrician. I think that's the 12th time I've said it, but I'm very proud of that. And I'm very proud of the advocacy that the American Academy of Pediatrics has put forth in cooperation with the CDC and making sure that we as pediatricians and as healthcare providers, such as in the family practice arena who do pediatrics, that we have products that can be quickly accessed and are very useful to the clinicians that are out seeing these patients, and they know what they need to know what to do. Also, I want to remind everyone that in addition to the webinar and the information that is coming out tomorrow and Thursday as part of the expert panel at the CDC, that the AAP will be having a webinar on September the 5th, 2017, called Beyond the Basics. And this is going to specifically focus on vision and hearing. So I think for those of us that are involved in the Zika registry, as Rachel, I think this will be a very useful webinar, and it will provide more information on those specific concerns that we need to be aware of in terms of the ocular and the audiologic findings with Zika. And finally, and I had mentioned the arthrogryposis article. Let me correct myself. It was in the British Medical Journal, but it is referenced here. And again, an excellent piece of information that I think you would find useful in terms of looking at the orthopedic injuries. And finally, the CDC has done a lot of information, a lot of work on Zika. As we're doing, there will be more to come, but I think, again, for the sake of our patients and for the sake of the public, we want to do all that we can to learn about this, to be able to prevent what we can, but also to be able to identify and manage infants that have been exposed to Zika and could have congenital Zika or other findings consistent with Zika. And with that, I'll turn the program back to Ashley, and then I think Rachel will be next. So,
thank you so much, Dr. Landers. Rachel Montgomery is our next presenter.
Thank you, Dr. Landers. So today I will be discussing the follow-up of infants with either confirmed or suspected Zika virus exposure. The objectives that I will cover today include defining best practices in newborn hearing screening for infants with possible Zika virus exposure. I will explain the follow-up and referral process for infants with congenital Zika syndrome or other birth defects. And finally, I will discuss the birth defect reporting procedure and purpose of the U.S. Zika Pregnancy and Birth Defects Registries. So as Dr. Landers mentioned, the CDC does recommend the auditory brainstem response, or ABR test, to be completed for infants that present with abnormalities consistent with congenital Zika syndrome. The ABR testing is the preferred test to detect hearing loss resulting from neurologic damage. The ABR screens the inner ear as well as the auditory nerve. A soft click is presented to each ear while electrodes record the response as it travels between the ear and the brain, and the response is then analyzed to determine how well the inner ear and the auditory nerve are working. And I would like to mention that currently 75% of birthing hospitals in Alabama use the standard ABR method for newborn hearing screening, and the other 25% use other methods to include the otoacoustic emission, or OAE testing, which does not test the inner ear or auditory nerve. So this is an infant receiving an ABR test. As you can see, there are sensors that are placed on the infant's head, shoulder, and neck. And there are also earphones placed over both ears. It is recommended to perform the test in a quiet environment while the infant is sleeping. And we do have a training video on the Alabama Newborn Hearing Screening webpage that demonstrates proper technique in performing ABR screening. And it can be found at www.alabamapublichealth.gov/newborn screening. So according to the Joint Committee on Infant Hearing, both ears should be tested when an infant receives the hearing screen. They should be screened by 1 month of age. Diagnosis or diagnostic testing should be completed by 3 months of age, and referral to early intervention by 6 months of age. So this is a summary of the CDC guidance for newborn hearing screening for those infants with confirmed Zika virus infection. So the infant should be referred for ABR testing before 1 month of age if initially screened using only OAE testing. And ABR should be performed at age 4 to 6 months of age if the newborn screen was normal. And then finally, referrals to the appropriate specialist should occur as soon as possible if hearing results are abnormal. So this slide provides a directory of state audiology providers, which can be found at www.edipals.org, or again on the Alabama Newborn Hearing Screening webpage provided. So this slide highlights the Zika infant follow-up process. And so to summarize, our Zika staff often will receive a referral from the Bureau of Communicable Disease for a Zika positive or suspect positive pregnant woman. And once the mother delivers, we will then follow the infant by contacting the hospital of birth or the primary care provider to ensure that infant testing for Zika virus has been completed. So we do send information to the hospital of birth or to the primary care provider, which includes a Zika notification letter. It just states that the infant referenced was born to either a confirmed Zika positive mother or was reported to have abnormalities consistent with congenital Zika syndrome, and lists the steps as previously discussed by Dr. Landers. We also do send a medical release form to obtain medical records for data abstraction. And we do send several CDC resources, some of which Dr. Landers has previously reviewed. So I'm just going to skip through these. This is the pediatric toolkit that Dr. Landers went over. Also, we send the Bureau of Clinical Laboratories guidance for specimen collection. This is the guidance for Zika virus specimens for fetal loss or at time of birth for collection, shipping, and testing. It includes contact information for the Bureau of Clinical Laboratories in the event there's any questions related to specimen collection. Again, this is the CDC assessment of infant hearing, which I previously reviewed this resource. This is just a flow chart that assists with determining the appropriate steps to take for infant hearing screening. Again, we also send, as Dr. Landers reviewed, the CDC guidance for measuring head circumference. And finally, we provide the CDC roadmap for parents. We encourage that providers discuss this, that reviews the screening and testing that a baby may receive with the family. And so our goals for follow-up include to ensure that the infant receives appropriate evaluation and outpatient management per the CDC guidance. We also want to make sure that we monitor these babies up to 1 year of age as recommended by the Centers for Disease Control and Prevention. And if abnormalities are present, we want to ensure that a referral has been made to the appropriate specialist as well as to early intervention. So as mentioned, we want to ensure infants are referred to early intervention. It was created as Part C of the Individuals with Disabilities Act. Early intervention sole function is school readiness. Eligibility criteria includes that a child must be between birth and 3 years of age, and they must be at least 25% delayed in one or more of the 5 developmental areas listed, to include communication, physical, adaptive, cognitive, and social emotional. In order to refer an infant, the provider may complete the child find form shown and fax to the number listed. This form can also be found at the Alabama Department of Rehabilitation Services website at www.rehab.alabama.gov. Or you may contact the toll-free number provided for more information at 1-800-543-3098. So at this time, we would like to show a brief video that will discuss the purpose of the U.S. Zika Pregnancy Registry.
Hello, I'm Margaret Lampy, a nurse scientist with the Pregnancy and Birth Defects Task Force for CDC's 2016 Zika virus response. Although Zika virus was discovered more than 70 years ago, microcephaly and other birth defects associated with Zika infection during pregnancy are a recently recognized phenomenon. As of April 2016, CDC experts concluded that Zika virus infection during pregnancy causes microcephaly, a severe birth defect, and other serious brain abnormalities. However, the timing, absolute risk, and full range of outcomes of asymptomatic and symptomatic Zika virus infection during pregnancy are not yet well understood. To understand more about Zika virus infection and the risk for adverse outcomes during pregnancy, CDC established the U.S. Zika Pregnancy Registry. CDC is working with state, tribal, local, and territorial health departments to collect information about pregnancy and infant outcomes following Zika virus infection. Pregnant women are eligible for the registry if they have any laboratory evidence of possible Zika virus infection during pregnancy, that is, positive or equivocal test results regardless of whether they have symptoms. And congenitally exposed infants born to these women are also eligible for the registry. Healthcare providers, particularly those caring for pregnant women or infants, are essential to the success of the registry. CDC encourages you and your clinical colleagues to work directly with health departments to report information to the registry. Here are 4 steps you can take as a healthcare provider to participate in the registry. First, identify pregnant women with potential exposure to Zika virus and infants with suspected congenital exposure to Zika virus. Ask pregnant women about travel to an area with active Zika transmission or if they've had sexual contact with a man who lives in or has traveled to areas with Zika. Contact your health department to arrange laboratory testing for Zika virus infection. You can access clinical guidance and testing algorithms for pregnant women and infants who may have been exposed during pregnancy or the periconception period on CDC's website. Second, report information about pregnant women with any laboratory evidence of Zika virus infection, as well as information about infants with any laboratory evidence of congenital infection. You can use reporting forms provided by your health department. Third, collect pertinent clinical follow-up information about these pregnant women and their infants and provide it to your health department or directly to CDC registry staff if asked to do so by your health department. Inclusion of infants who appear healthy at birth is important because short and long-term effects of in utero exposures remain unknown. And last, quickly notify your health department or CDC registry staff of adverse events such as spontaneous abortion, fetal death, or birth defects. You may be wondering, what will the registry tell us and how is that information relevant to me and my colleagues? CDC is rapidly translating new findings from the registry into messages for the public and updating clinical guidance. For example, CDC recently updated the recommended testing algorithms for pregnant women to reflect accumulating data on fetal abnormalities, including microcephaly, intracranial calcifications, and brain and eye abnormalities. In May 2016, CDC began reporting the total number of pregnant women with Zika virus infection from both the U.S. Zika Pregnancy Registry and the Puerto Rico Zika Active Pregnancy Surveillance System. And in June 2016, CDC began reporting adverse outcomes, including live-born infants with birth defects and pregnancy losses with birth defects. The numbers are now updated weekly and available on CDC's Zika website. Data from the U.S. Zika Pregnancy Registry will be critically important for arming you with the information you need to counsel and care for pregnant women and their infants. CDC continues to evaluate all available evidence, including data from the registry, to update clinical guidance. Data from the registry will also be used to plan for services for pregnant women and families affected by Zika virus and to improve prevention of Zika virus infection during pregnancy. CDC's top priority for the Zika response is to protect pregnant women and women of childbearing age. We hope you will join us in this effort, and we thank you for all that you do on behalf of pregnant women and their families. For more information about Zika, including clinical guidance and tools for healthcare providers, please visit CDC's website at www.cdc.gov/Zika. For more in-depth information about participating in the registry, you can contact your state, territorial, tribal, or local health department or visit CDC's U.S. Zika Pregnancy webpage. Thank you for watching.
So again, just to reemphasize, the purpose of the U.S. Zika Pregnancy Registry is to understand more about Zika virus infection by collecting information about pregnancy and infant outcomes. And again, aggregate data is used to update recommendations for clinical care, to plan for services for pregnant women and families affected by Zika virus, and to improve prevention of Zika virus infection during pregnancy. And here is the link, again, to the CDC website for more information regarding the U.S. Zika Pregnancy Registry. So in conjunction with Zika birth defect surveillance, the Alabama Department of Public Health plans to collect information on other birth defects as part of the National Birth Defects Prevention Network. A birth defect is defined as a defect, a structural, functional, or biochemical abnormality, regardless of cause and irrespective of any known genetic or environmental association. Birth defects are the leading cause of infant mortality, accounting for more than 20% of all infant deaths. The department was awarded funding by the CDC to establish a birth defect surveillance registry. Currently, we are in the process of establishing the administrative code to specify the type of information to be provided and to determine persons who will be required to report. The purpose of the birth defect surveillance registry is to monitor birth defects for changes in incidence or other unusual patterns suggesting preventable causes, and to ensure long-term follow-up and delivery of service. It is also to ensure children identified with birth defects are placed in a system of care and receive appropriate intervention services. So here's the contact information for our Zika surveillance staff with the Bureau of Family Health Services. So we encourage you to contact us with any questions that you may have. And again, to re-emphasize, we encourage you to also look for future updates on the guidance of Zika as it relates to pregnancy and infant surveillance. And as Dr. Landers mentioned, the live webcast tomorrow that will be hosted by the CDC in collaboration with the American Academy of Pediatrics as well as the American College of Obstetricians and Gynecologists. Thank you.
Thank you all so much for presenting. We have a couple of questions, and I do want to remind you who are watching out there, if you have a question, please email us or give us a call. We'd love to answer it. I'm going to go to a couple questions that we have that have been emailed in. Dr. Landers, this one's for you. You mentioned that you're a pediatrician. Have you encountered any newborn children with microcephaly or any other Zika conditions? And if so, can you tell us a little bit more about your experience?
Well, as a pediatrician, of course, I have been in private practice and also worked for the Alabama Department of Public Health. And I have seen children with microcephaly, certainly in my career. More recently, because of the role I have had, I have not specifically seen children that have been potentially exposed to Zika myself, although I have spoken with several pediatricians regarding infants that are of concern. And I think when we see a child with microcephaly, certainly in this environment that we're concerned about Zika or we're worried about a Zika exposure, the first thing we need to do is go back to our information and talk with the parent, talk with the mother, see what epidemiologic information could be there, and if appropriate, certainly follow our Zika algorithm to determine what those infants need to have done and what testing needs to be done and what further follow-up needs to be done. You know, in my career of having seen children with microcephaly from other reasons, of course, it really depends on the situation. I mean, these infants obviously have significant problems of developmental delay, motor delays. They can certainly have other situations to occur, such as seizures. I mean, there are just many situations that can occur. But I think in answer to your question, we have to be concerned about not only the finding of microcephaly, but the other findings that could go along with congenital Zika, as well as the appropriate testing and the follow-up. And I would just like to reemphasize what Rachel said about appropriate subspecialty follow-up, getting these patients enrolled in the early intervention programs, because we want to give the children all that we possibly can. One final comment I would like to make is I just happened to notice that Dr. David Schoenfeld, who is a well-recognized pediatrician who deals with developmental and behavioral issues in children, has been an advocate for children in disasters, has also done a video presentation, and it's on the AAP website, concerning the psychological factors and the counseling and the issues that parents will face with a child who has a severe condition such as congenital Zika. So I would refer you to Dr. Schoenfeld's video as being a very excellent discussion of we've spoken a lot about the physical, we've spoken a lot about the testing, but what if this were our child? And how would we manage this? And how would we navigate the healthcare system? And how would we work with what's available in the educational systems and the social systems and the healthcare system? So I think that is another realm that I would urge people with interest to avail themselves of. Thank you.
Thank you. Dr. Harris, I think this may be a question for you. Can you tell us a little bit more about the relationship between Zika and Guillain-Barré syndrome? Sorry about that.
Yeah, no, you said that just right. Yeah, Guillain-Barré is a type of autoimmune disease that results in a paralysis that's usually temporary. It's often associated with a form of ascending paralysis, that is, paralysis that starts in the lower extremities and then extends upwards. People who get Guillain-Barré don't always have a known cause. Sometimes Guillain-Barré occurs for no apparent reason. But it is thought to be an autoimmune disease in which antibodies attack certain cells that are part of the nervous system, and probably this is triggered in most cases by some type of infection. It's not unique to Zika at all. I think, as we mentioned earlier, there are many other types of infections that are well known to be associated with Guillain-Barré. Perhaps the best known, or the one that's been best characterized, is Campylobacter, which is a bacteria that causes gastroenteritis and bloody diarrhea. Many patients who have this type of gastroenteritis will subsequently develop this paralysis, and there's just something about that particular organism that activates the immune system in a way that antibodies, instead of attacking the bacteria, also will attack the immune system. And so it's something very similar with Zika. I would tell you that the numbers of Guillain-Barré patients who've been found in the course of the Zika epidemic are extremely small. They're on the order of, a dozen or two out of the, around 40,000 patients that we've seen in the continental U.S. and in Puerto Rico. So it's a very small percentage, but it is a statistically significant association. And again, like we mentioned earlier, it's not surprising that we would find this once we start looking for it. There just seem to be a number of infections that activate the immune system in this way, and in that way, Zika is no different.
Thank you so much, Dr. Harris. Just a reminder, you can call or send us in any questions that you have. We do have a few questions here in the room. So, Sharisha, will you go ahead with your questions?
Sure. I actually wanted to add a note first coming from newborn screening, and that is the fact that while we've talked about following the Zika babies up to 1 year of age, that Zika in and of itself is a risk factor for hearing loss. So babies that may pass their ABR in the hospital, that specifically is one of those things that need to be monitored even into the toddler years to ensure that we're not missing something that would interfere with speech and language development later on. But my question, and it's a little more general than just Zika and newborns, I say that, in doing the birth defects registry and looking at more congenital anomalies than just those that we know are caused by Zika, do we anticipate, and this is for anybody, do we anticipate that we may begin testing for other congenital infections, such as possibly cytomegalovirus or others that cause those types of anomalies?
Rachel, do you want to take that, or you want me to take that?
You can take that, yeah.
I think we've had some discussion. Certainly we know, and as the caller had asked about my seeing patients with congenital Zika. Fortunately, I've not seen patients with Zika. I have seen patients with microcephaly and other clinical conditions. But we mentioned CMV, and CMV is obviously something that we know has a lot of aspects, and specifically we have a concern about hearing, when we're talking about CMV. So while at this point in time we do not have a program in Alabama to do this, we have had discussions specifically with physicians from the UAB Department of Infectious Diseases about this particular virus, and perhaps some future follow-up and some future evaluation. And Rachel, I think you were involved in those conversations, so what else do you have to add to
we
that?
We have actually spoken with Dr. Karen Fowler at UAB, who's done a lot of research with congenital megalovirus, and she actually just recently spoke at our newborn screening conference about that, and it's linked to hearing loss in infants. So we've had discussions about that, and I know that they are interested in testing those babies that fail their newborn hearing screening, testing those infants. So I know we'll continue to have discussions about that. So,
thank you. And I think it's useful for us to have the interaction. We've spoken a lot about CDC and the AAP today, but also remind persons that we have a lot of discussions with both our private health care providers as well as our university-based, such as UAB, the University of South Alabama, just mentioning two places that have pediatric residency programs in the state of Alabama, so that these conversations can continue, and based upon research and data, we can determine going forward. As when I was a young physician, we tested for PKU, and that was it. I mean, that was all we tested for. And now look at the panel that we have in terms of newborn screening, and how much difference we've been able to make in terms of, for example, hypothyroidism, for example, congenital adrenal hyperplasia, cystic fibrosis, and many others. We've been able to make a huge impact as a result of our newborn screening program. I'm very proud of what the state of Alabama does.
Okay, well, I have one other, and this gets a little further away from Zika. But Dr. Harris, you talked about the whole family of viruses, and with all the attention that Zika has gotten, has it led to any concerns that we may see other issues with some of the other flaviviruses, such as, say, dengue fever, anything like that?
Yeah, no, that's a very good question. So dengue fever does occur in the United States sporadically. There's actually been a fairly large-scale outbreak in the state of Hawaii in the past couple of years with a couple of hundred cases. But even in the mainland United States, we occasionally do see cases of dengue. And again, it's not surprising. Dengue can be brought in by travelers. We certainly have the mosquito vector here. And so in South Florida or in Texas, sporadic cases of dengue are not that hard to imagine. Chikungunya has been imported. We've not, to my knowledge, had locally transmitted chikungunya, although I'm not 100% certain that we haven't, but it would not be surprising to see that. I think one thing that we're fortunate to have in this country is that we do have a standard of living where these sustained mosquito-transmitted illnesses don't seem to keep on going the way they do in the developing world. And so, people, for example, tend to live indoors, and people frequently have air conditioning. People have access to medical care and to insect repellents if they need it. We have the ability to educate people in a way that helps to keep them safe. And so even though we have the same mosquitoes and we have the same risk from the standpoint of travelers with the disease, we haven't really seen sustained transmission. And so while we could, hopefully we're not going to see that.
I believe we have a few more questions down here in the audience. Would you like to ask your question?
Sure. Dr. Landers, tell me, have you heard anything about late onset microcephaly?
Well, in terms of, if you look specifically at the definition of microcephaly, I think we're really talking about, obviously, head circumference is going to grow during childhood. I mean, we all know that. In terms of a late onset, I think what we have to recognize is that, just because you pass out of the newborn screening time and you have good head circumference, that we need to continue to monitor head circumference. I mean, we're not just talking about Zika, but we know that other congenital infections can affect head circumference. Now, again, what we would be looking at as in Zika is these kids having a really severe microcephaly at the time of birth and having, the collapsed skull, as I mentioned, the redundant scalp folds, etc., as opposed to a child that was borderline or fell under, just barely under the percentile, and then on throughout early infancy and toddlerhood did not seem to grow upon a curve. So I think we have to keep an eye on that, not only from the standpoint of Zika, but other insults to the central nervous system, not just congenital infections that could cause something of that nature.
Okay, so that's not necessarily something that would be, we would specifically look for with Zika, but it's a potential.
It's potential, but we also would be looking for, again, other congenital infections or other insults to the central nervous system that could have occurred in utero or shortly after. So I think we have to be aware of that. And again, in my training, not just measuring the head circumference at the time of birth, but measuring the head circumference really, up through early toddlerhood. I mean, that's just, of course, that's when the kids really fight you on the head circumference. That's when you really break the tapes, but it does not deter you from doing your head circumference and recording that as you record your height, as you record your weight, and as we now use BMI. So again, it's just another part of a good physical examination in infants and children.
Okay.
So.
One other question, and this may seem pretty basic, but I know you mentioned, especially in some of our level 1 facilities that are delivering, that there might not be any ophthalmic expertise available while the baby is still in-house after birth. Is there a timeline in regards to that type of exam? I know it's initially after birth, but is there a timeline that it needs to be done in?
Okay. As opposed to testing, and again, I may be incorrect on this, but the information I'm reading is not that has to be done immediately, the ophthalmologic, so it certainly can be referred. But again, if we look at pediatric ophthalmologists in the state of Alabama or ophthalmologists that are comfortable doing exams with children, that tends to be in the larger cities or around the medical centers. So I think that gets back to, as Rachel has talked earlier, about good case management and good coordination with parents up to and including, having the social worker involved to ensure that, parents have transportation or a way to get to a facility. I mean, again, if you're born in a hospital that has the level 1 capacity, certainly they do great work, but this is where perhaps a child with an extremely severe situation, a child that came into box 1 on our algorithm, there should be consideration and discussion of whether that child with the severe findings that may be there should go ahead and be transported to a neonatal center or a neonatal unit where they would be able to not only access, additional testing and follow-up, but also subspecialty referrals. So if possible, if we have an infant that really falls into the category and truly has findings, and the mother had Zika and the child has Zika, and I think this is where we get back into case management, making sure that we can get that child to the most appropriate level of care so that early access for this can be done. Not only the testing, but the testing we're really talking about the first couple of days, but again, subspecialty referral and early, doing an appropriate ultrasound of the head. Again, the capacity of that hospital, that administrator and that physician knows their capacity there. So establishing referral patterns early on for patients of this nature. Sure.
Does anyone else in the room have a question? All right, with that, thank you so much to our presenters for sharing their knowledge with us, and thank you for watching. You'll be able to watch this program on the on-demand section of our website. You can go to alabamapublichealth.gov/ALPHTN.